Hi, Learning Plan Part 5, Learning Plan 1 Part 5 right now. Picking up on about slide 33 right now. Now, this just gives you a scenario where we're going to talk a little bit about some concepts here. You know, you're administering medications to an 88-year-old female patient who has a history of liver disease. She's recently eaten breakfast. Her blood pressure is 88/60. She gets medications orally, although it can be given IV or intravenously. It's an extended release tablet. The medication you're administering is considered teratogenic with a narrow therapeutic index. It's got a high affinity for plasma proteins, and the medication has a long half-life. There's a lot of terminology in there. Some of them we've talked about. Some of them we haven't yet, and we're going to now. What are some things we have to think about for this patient? Well, 88 years old. You suppose that might have an effect on medication absorption and elimination? Probably. Yeah. Generally, the very old and the very young have different absorption and different effects. So when you have an 88-year-old, you're going to do things differently than a 28-year-old. She has a history of liver disease. And we just talked about that, didn't we? Liver disease will affect the elimination of drugs that are hepatically excreted. So are we going to give her Tylenol? Probably. Probably not. I have to keep drinking water, otherwise I'll stop talking, and then the lectures are done. Blood pressure is 88/60. Now, if we're giving her Tylenol, is that let's say ibuprofen? Will that affect her blood pressure? No. But what if we're giving her an extended release blood pressure medication? That will be a problem, because 88/60 is low. It's low. Now, we have to always consider not one number generally, but you want to look at her pattern. If this patient, if this resident, if this client, however, whichever word you want to use, always has blood pressures from 84 to 90/60, and that's her normal. That's her normal. It's still low, and you'll still be very careful with medications that could affect blood pressure. But if her blood pressure is normally 120/80, 130/80, and you check it and it is 88/60, what would you do right then? Just kind of keep an eye on it, make a note of it, chart it somewhere. If you have that big of a drop, if you have a 40 or 50 point systolic drop, you probably want to call the doctor immediately. Now, is that a fatal blood pressure? No. No. But if that's a major change, major changes are always considered a problem. You always want to keep an eye on big changes. So we have to take that into consideration. It's an extended release tablet. Now, the medication can be given intravenously. Now, which of those medications is absorbed faster, IV or oral extended release tablets? The oral extended release tablet is going to last longer. If you give that medication IV, is it extended release or is it boom? It's boom, right? I'm not going to clap twice because I already woke you up once. Now, teratogenic. We didn't talk about teratogenic. What is teratogenic? Any idea? Teratogenic is a drug that will cause a congenital defect in an infant whose mother takes that drug while pregnant. Any problems here? Any chance of this patient being pregnant? Probably not. But what about the nurse? Remember, we talk about absorption. Absorption is any route. And if you give a person a tablet, if you touch that tablet with your skin, it's potentially absorbable through your skin. Not guaranteed it will. but it's not guaranteed that it won't. So you will always use drugs, and in general, if you know you're pregnant, you will never administer a teratogenic drug at all. If you are only in that category of potentially, possibly pregnant, in other words, a young woman of childbearing years, you'll be very, very careful when you work with teratogenic drugs. But if you know you're pregnant, you won't touch them. Okay, so there's that. What are some? The other term? I just lost that page. A very narrow therapeutic index. Remember, we talked about therapeutic effect. That's the desired effect. So a therapeutic index means the level in the body from where it's therapeutic. If you are below that level, it does nothing. If you're above that level, then you start developing side effects and toxic effects. It's got that very narrow window of ideal levels. So we're going to be very careful with this. We might have to do blood tests to determine the level. We talked about digoxin. I mentioned digoxin being a drug that slows the heart and makes it pump harder. It has a therapeutic window. And they will do a blood test called digoxin levels or DIG levels. It's spelled D-I-G, so it looks like dig, but it's pronounced DIG levels. So they will check a DIG level occasionally or daily, depending upon what's happening. And they will look for the therapeutic level. Okay. Some antibiotics, most commonly a very powerful antibiotic called vancomycin, has a therapeutic level. And they will check peaks and troughs. A peak is the highest level in the bloodstream after administering. The trough is the lowest level before administering the next dose. You don't want to be below you want to stay within this level. So we'll talk about those kind of lab tests in further learning plans. In this class, we're going to be covering a lot of different sciences, not just pharmacology, but we're going to talk about labs, we're going to be talking about anatomy and physiology, we're going to be talking about medications, disease processes, so we're going to be touching on pathophysiology. We're going to be touching a lot of different areas of nursing, not just pills. And this medication is bound to plasma proteins. So it's a high affinity, meaning it loves to clump up with plasma proteins. So if a person is malnourished and has a low plasma protein level, where's that drug going to go? She's going to lose it. So we need to make sure that the patient has enough protein in her blood so that the drug grabs onto it. And the medication has a long half-life. Half-life we didn't talk about before. Half-life is simple. The time required for elimination to reduce the concentration of the drug in a body to 1/2 at the administration. So the half-life. And like radiation, drugs are not excreted in a specific block of time. They get broken down half at a time, and each time that half gets smaller, but it takes a long time to get to zero. So if the half-life of a drug is 6 hours, that does not mean in 12 hours all the medication is gone. It means in the first 6 hours half is gone. In the next 6 hours half of what's left is gone, and so on and so forth. So that's why I can stay in the body a long time. A long half-life means it's in the body for a long time. So those are some of the things we need to consider when we give medications to patients. How old are they? What's their basic health history? What are their current vital signs? What's their current nutritional status? Are they eating or not eating? Are they drinking fluids or not drinking fluids? Are they urinating or not urinating? Have they had a bowel movement or not? Are they active and walking or not? What's their mental status? What's their pain level? There's so many things we have to look at before we give that pill. There are some pharmacokinetic is another medication, another term we need to talk about. Pharmacokinetic is the study of drug distribution rates between various body compartments after the drug has entered the body. Now this talks about absorption, distribution, metabolism, and excretion. 4 areas. Pharmacokinetics touches absorption, distribution, metabolism, and excretion. We've already talked about absorption. That is the blood being drawn into the body fluids within the body. Distribution. Come on, we know what distribution means, right? That's where when you put that fentanyl patch on the person, it absorbs into the tissues, gets into the bloodstream, and then the bloodstream carries it everywhere. So that is the movement of the drug throughout the body. Metabolism. Key concept here. Metabolism is the process which converts a drug to a more water-soluble form. A more water-soluble form. Why is that important? Why do we have to have a water-soluble form? Because we are water-based creatures. 70% of our body is water. So we need to make sure that whatever medication we take, it is in a water-soluble form, meaning the water within our tissues can break it down, can dissolve it, and then it can be drawn into the tissues. That's metabolism. Metabolism refers to many different things. In this case, in terms of pharmacology, metabolism is the process which converts a drug to a more water-soluble form. And then we talked about excretion already. That is the elimination of the body out of the system, out of the body system. And it is generally renal system or kidneys, hepatic system or liver. So, have we got that now? Pharmacokinetics. 4 concepts for pharmacokinetics. Absorption, distribution, metabolism, elimination. Drugs in higher concentrations will be absorbed more rapidly than those in low concentrations. So, for example, let's look at morphine. Morphine, here's something very important. When it comes to medications, you'll be giving medications IV, and they will be, you will draw them up. You draw maybe 1 milliliter or 5 milliliters of something, but we don't give medicine by the milliliter. We give medicine by the milligram or gram. Medicine is a weight. It's dissolved in fluid. You can get pre-filled syringes of morphine. You can get syringes that have 1 milligram per milliliter, 2 milligrams per milliliter, 5 milligrams per milliliter, 10 milligrams per milliliter. In every case, if you give 1 milliliter, you could be giving anywhere from 1 to 10 milligrams. That's why we never say, go give 1 milliliter of morphine. How much morphine do you want? 1 or 10? Do you want to get rid of the pain? Do you want to make them stop breathing? So we give it by milligrams. But looking at those syringes, if you give a milliliter of 1 milligram per milliliter to one person, or you give the 10 milligram per milliliter, obviously if you give this one higher concentration, it will be absorbed faster. Now sometimes on some medications you give a lot of medicine right up front, and then you give much lower doses after that. That's called a loading dose, okay, or a priming dose. Usually, I'm going to use the term loading dose because that's the most commonly used. For example, Plavix is another medication that prevents clotting. Almost always, you will give a loading dose of many tablets, sometimes as many as 8 tablets. It's a loading dose. So you get a lot of medicine in the gut, and it's absorbed really quickly. And then after that, you give just 1 dose at a time. Right? So A loading dose will be a big bucket load of medication, so it's absorbed quickly. And then smaller doses to just keep that therapeutic level where you want it. Now, you know what? Next round, we're going to come back and talk about a few more terms, and we're going to keep working on this because these are some key concepts that if you don't get, the rest of this class is going to be mumbo jumbo, and I don't want that. So, come on back for more.